Baseball player with an ulnar collateral ligament tear, third degree.
Patient history. Robert is a 19 years old baseball player. At a high school level, he has been practicing baseball ever since he was a little boy. He's very active. He practices 3 to 4 days a week. He has never had an injury before. He just complained of elbow pain. He was in a school tournament pitching a ball doing an aggressive overhead throw when he felt a pop after throwing, following by intense pain. Signs and symptoms. Some of the most common symptoms are popping, cracking, and grinding, pain and tenderness, swelling of the joint, tingling or numbness, instability of the elbow, special test, valgus stress test, MRI scan and X-ray were needed in order to get more details of the tear.
There are three grades of ulnar collateral tear. The first grade is the ligament is stretched but not torn. Second grade, the ligament is stretched and might be partially torn. And the third grade is the ligament is completely torn. What is an ulnar collateral ligament? The ulnar collateral ligament is a ligament that runs on the inner side of the elbow to help support when performing certain movements, such as throwing. It originates at the medial epicondyle of the humerus and it inserts into the base of the coronary process of the ulnar. The ulnar collateral ligament is composed of three bands: anterior, posterior, and transverse oblique. The following picture is a picture of the UCL surgery reconstruction, better known as Tommy John surgery. To restore the damaged tendon, the surgeon uses a tendon of the following parts of your body: palmatis longus of forearm, hamstring tendon, extensor tendon of the great toe. The surgeon makes an insertion on the medial side of the elbow, exposing the UCL ligament, then holds our drill in the humerus and ulnar bone at the point where the UCL originates and inserts. The removable tendon is inserted in the figure 8 to stabilize the elbow. The insertion is closed and the elbow is placed in a brace. After the surgery, recovery phase begins.
Rehab program phase 1, inactive phase. The goals in this phase are to decrease edema, decrease pain, swelling, protect the healing tissue, brace, ice or modalities are applied. It is recommended not to perform any physical activity with the damaged arm. However, the person can still perform any light exercise such as cardio.
Phase 2, proliferation. Pain spans should be resolved or eliminated. The goal in this phase are to gradually increase range of motion and flexibility, promote healing tissues, regain and improve muscle strength and endurance. Exercises are introduced to the rehab routine program, beginning with passive, gentle movements such as wrist flexion, extension, supination, and pronation, as well as elbow flexion and extension, moving along with active exercises by performing the previous exercises. Moreover, instruments such as elastic bands are utilized to increase resistance and perform the following exercises, such as abduction, external rotation at 0 degrees, abduction, internal rotation at 0 degrees, shoulder abduction at 90 degrees, side slide external rotation. Also, isometric and isotonic exercises are introduced to increase mobility. For one-to-one patient routine, patient must be working in lower extremities by performing squats, cycling, and even leg machine exercises. Phase 3, resisting phase. The third phase of UCL reconstruction rehabilitation involves a progression of activities to prepare the athlete for high-level stress situation and participation in sports. The goal of this phase are to gather increase strength, agility, and endurance, maintain restored deficiency patterns, Some of the exercises that can help to reach these goals are tubing, ABCs, bodybuilding, push-ups, diagonal pattern, PNF, D1, D2, eccentric elbow flexion and extension, chest pass, bicep curls overhead press, single leg stand, box jumps, burpees, clapping push-ups. One-to-one patients, it is important to keep activity movement to maintain muscles and joint in action. Therefore, cardiovascular activities such as walking, jogging, or running for 15 to 30 minutes a day is recommended. Leg extension and flexion are also important to improve power and velocity at the time of pitching. Therefore, utilizing a leg machine it is great recommendation starting from light to heavy weight, depending on the patient's conditions. Moreover, trunk rotation exercises are recommended for better stability of the hip rotation at the time of throwing.
Phase 4, aggressive phase. The goal of this phase are to improve balance, coordination, and agility. Athletes should be able to perform exercises that are focused on ability to control their own body during rapid, complex, and skillful activities. Focus on strength, speed, power, balance, and coordinations. Balance exercise. Medicine ball, lateral swing hoop, lateral ground hop, elevator from split squat, single left deadlifting, coordination exercise, catching a tennis ball, juggling, ball dropping, catching without seeing the ball direction, agility exercise, bunny hops, side hops, running and switching drills, box jump, cone ball running drills. According to the article Rehabilitation Following by Ulnar Collateral Ligament Reconstruction of Athletes, it takes about a year for an athlete to fully return back to play. Phase 1 covers week 0 to 3, where a brace is introduced after the surgery and gradually increased 5 to 10 degrees of motion every week. Week 4 to 7, passive and active exercise are applied. On week 5, the brace is removed. Week 8 to 14, focus on strength and endurance exercise. Week 14 to 32, focus on aggressive exercises.